Devik. So say Devik is Miss Harrington, right? He has right shoulder pathology, whatever the case may be. It's something going on with his right shoulder, but we don't know what it is, right? Okay. So I say, okay, I'm about to start my objective examination. I'm gonna try to do everything with him supine. So I'm gonna get the V. I'm gonna come right here like so. Say, I'm gonna notate, okay, full range of motion with flexion, normal, firm, infield. All right, that's good. I'm gonna come and assess. This not gonna take me long at all. Abduction, full range of motion, normal, firm, infield. Very good. External rotation, full range, normal, firm. Internal rotation, full range, normal, firm, infield. So I didn't capture flexion with him supine. I haven't looked at extension, but I've captured flexion, corona abduction, internal, external, just that fast. All right, I'm gonna go around to the involved side. This is the involved side. Just act like you hurt. Okay, that's as far as he's go. Oh man, this is uh abnormal, firm infield. All right, or it could be deemed abnormal, firm, painful infield if he has pain with it. This is all in web PT. All right, different ways you can categorize it. Ooh, this as far as he go. This is abnormal, firm, infield. Okay, painful. He winced with it, and I haven't even gotten to joint accessory yet. I'm gonna hold off on that. I'm gonna come back to that next. So I says flexion, abduction. I'm gonna come to about right here. I'm gonna keep him at a 45-degree angle because he has pain at 90 degrees of corona abduction. So I'm not going to take him that far. So I'm going to assess and notate that I'm assess passive at 45 degrees. So this is as far as he can go. I'm going to say abnormal, firm, infield, no pain. All right. Internal rotation, say if this is as far as he can go. All right. He winced with this. Abnormal, firm, infield, and it's painful. And I'm moving on, right? All right. So now I got my goni. So really, I can skip this. I can go goni or not. Let me see you go into flexion. Full flexion like so. He knows the motion. Come back. Go. I want you to make this movement for me, going all the way up as far as you can. Very systematic. Come back. All right, he got full range of motion with flexion, corona abduction. Come right here. I have my towel roll for him. This is the movement I want you to make. Go back like that for me as far as you can. Then I got my goni and I measure this, right? Now, when I measure this with my goni, I'm probably sitting in my scooter rooter. I leave the goni right there when I read my measurement. Come right here. Go full range. So, all right. So this arm, he got full range. I take my goni and I read my goni with it in place. Then I write it down. So I don't do this with the goni. This is the goni. I don't do this with the goni. All right. I don't remove the goni from the patient. I make the reading with the goni right there. Didn't I tell y'all about this? All right. So if you take the goni away, you've already compromised most likely your intra-rater reliability or even inter-rater reliability if somebody comes behind you and do it. So for those who pull the goni away and measure it, those are inaccurate readings, most likely. All right. Keep the goni in place and make the reading. All right. So I done that quickly over here. Then take me like a minute or two. Then I go to this side. I get him to go through the motions that I want. I want you to make this motion right here. Go back for me as far as you can. All right. As far as he's go, I got my stationary arm aligned with the trunk. Right. We coming up with our own stuff around here. We create our own alignments. Stick to the alignments that's in Norkin and White. Because as soon as you start practicing out of what the textbook says, then it's going to become habits. Then you're going to become a shabby therapist. Stick to the book. Don't make up your own alignments. I saw somebody earlier had the stationary arms to going that way. I don't know who, I can't remember. All right, but I took a mental note. So line up stationary arm and your movable arm, leave it right there. Boom, 0 to 80 degrees, write it down, keep moving. A flexion. Come right here, line up your goni, fulcrum over the acromial process, stationary arm, parallel with the trunk. Now I know my movable arm is following the humerus. Line it up, boom. I leave it right there and make my reading. I don't take it away and do all this. What is this? What is this saying? I can't figure this out. Leave it right there and read it. All right, 0 to 80 degrees. That's what I got for coronal abduction. And you keep it moving. Now I'm gone. I'm done. I'm going back over here. Checking accessory motion. I'm not all over the place. It's very systematic. And all this is done with him in supine. Then I get him moving to other positions. So I don't have my thing. I don't have my good at loose pack position. Right here, I'm going to hold him in a loose pack position. I will have my wedge right here. Assess posterior glide. Come right here, block. Assess anterior glide. All right. I can come here also and get a good assessment of the inferior glide. Then I'm getting a sensory motion. I'm making a judgment. Oh, this is his normal side. So I'm just going to say normal, firm infills, smooth movement, no clicking, crepitus, none of that. So good. Let's compare. And I'm moving. You see what I'm saying? Woo, 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 woo. Considerable hypomobility with the inferior glide compared to the inferior glide over here. You see, that's a problem, Mr. Williams. We got to work on that, Mr. McWilliams. All right, come back, come right here. Let me assess your posterior glide. He's guarded, right? So he's guarding. I can't get anything. I'm gonna say on the Paris scale, considerable hypomobility. What grade is that? 2. Slide is 1. All right, so you got considerable hypomobility. Posterior. Did I check inferior? I didn't do inferior over here. So I did do inferior then. Yeah, I did inferior first. So I did inferior. So I didn't do interior. Good. I'm gonna compare interior. So he's guarded again. I would say hypothetically the one out there probably considerable hypomobility with that as well. All right. He's just stoved up. So now I know I'm gonna end up having to work on soft tissue and joint accessory motion. But now I go MSTT. So I'm gonna check his rotator cuff muscles quickly. Come right here. I can do all this supine. I want you to hold this position and don't let me move you. Relax, relax, relax. Hold this position. Don't let me move you. All right, good. So now he's resisting me. I'm trying to move him into internal rotation, right? So he's resisting external rotation. So what's fine for him to maintain external rotation, his infraspinatus has to fire, all right, and his teres minor. I'll come right here, hold his position, don't let me move you. All right, subscapularis has to fire. Any pain with those? I mean to ask about pain. No pain, good healthy muscle, good healthy infraspinatus, good healthy subscapularis. So I'm quickly checking his rotator cuff muscles. Come right here. I don't have to get him into full abduction for the supraspinatus muscle. Hold this position. Don't let me move you. Hold, relax. All right. But the thing is, textbook is showing that in sitting, right? All right. It's showing all those in sitting. But what am I doing? I got the knowledge. I'm still doing them, right? But I'm just keeping them in this position in the clinic. I'm just keeping them in the supine position. So I got the knowledge. For now, y'all gonna do textbook wise, but I got the knowledge of using my time efficiently, right? So I'm using my time efficiently in the clinic, but I'm still assessing the same muscle. Then I come over here. I'm comparing. I'm doing my MSTT. Hold this position. Don't let me move you. All right. Any pain with that? Weak and painful. So weak and painful. That's good. For me, that's good because now we're probably dealing with minor to moderate pathology, but not to complete rupture or complete tear. All right, come right here, hold this position. Don't let me move you. All right, any pain with that? So weak and painful. Again, probably moderate, I could say moderate, severe pathology, but not complete rupture, being that you have some pain. Because weak and painless is what I'm looking for. Come right here. I'm keeping him in the supine position. Hold this. All right. And then again, painful. So that one right there, I'm going to say he was able to hold it. I'm going to consider it strong and painful. So probably most involved, most of subscapularis, and for spinatus, more so involved in supraspinatus. So now what I would do, I would recheck these when I get him to sitting. So I can recheck them when I get him to sitting. Now, what if I forget to check them when I get him to sitting? I get them the next time in sitting. You see, but I'm using my time efficiently. So I'm showing y'all how to use the time efficiently. So just that quick: passive range of motion, active range of motion, joint accessory motion, MSTT. Now come up and sit up. All right, come over here. So quickly, I'm just thinking something. I'm ruling in and ruling out. He's just here with shoulder pain or some type of shoulder pathology, right? And so I'm gonna come right here, hold this. So Miss Harrington, she fell, right? On trauma to the body. So now I want to quickly rule out supraspinatus involvement. Hold this position. What am I doing right now? What test is this? So I bring him right, relax. This is Hawkins Kennedy. Hold this position. So most likely Hawkins Kennedy she had a fall. So Hawkins Kennedy can give you information about supraspinatus muscle, but it can also give you information about the joint capsule. So you got to be careful with that. So if the person report a positive pain with that, you got to ask them, where is it? If it's supraspinatus, they're gonna say, oh, top of my shoulder, or like right here at the supraspinatus insertion. Or they may say, man, it feels deep within my shoulder. So now that'll lead you to all your assessments for joint capsule. Then I come over here and compare. Come over here, hold it. He can't hold it. Then I know that's involvement of supraspinatus muscle from the fall. Something's going on. But I'm gonna go back and forth with my different special tests. I'm gonna compare non-involved, then involved. Then I got data to write down, special tests. Then I go, okay, I got to do some functional. I've done my passive. I've done my active range of motion. I've done my joint accessory motion testing. I've done my MMT, MSTT. I've done those. I've done different special tests to rule in or rule out. Now what's left? Functional. So what am I going to do functional? Okay, I could do, again, Atlas scratch test is functional, right? All right, I'm going to do this arm first. This is non-involved. Can you touch the top of your opposite shoulder? All right, good. Can you touch the back of your head? This is very quick. All right, and I'm looking at the quality of motion, how far you can go, etc. Can you touch the back of your lower back? All right, good. Let's see if you could do that with this arm. Let's see if you could touch the top of your opposite shoulder. And notice Miss Harrington only made it to her anterior chest. So I got work to do with her, right? I've only seen her for one visit since her fall, which was a evaluation. All right. Now, I got that, capture that, notate that, write that down. All right, can you touch the back of your head? All right, that's as far as he can go. Got to the ear. I'm like, okay, he's able to get to the ear. All right, but not the occipital lobe, or not even C2, C3, whatever, C4. All right, good. Come back. Can you make it to your L5? Can you touch your lower back? All right, good. So right here, I'll put that he probably made it to the gluteus medius region, or I'll describe that area as our greater trochanteric region, and that's it. Now I'm moving on. I got a problem list that I'm going to work on with this patient. This is my systematic flow, the systematic flow. All right. And so it shouldn't take that long, right? So when I assign somebody to Mr. Arrington, when he comes in on Monday, he's a FAMU heel slider. That's what I call him, because he graduated from FAMU and he's a big FAMU person. So when he come out and say, welcome FAMU heel slider, he one of my patients I have a whole lot of fun with. He's a character, but he's going to be a lot of fun. So I'm going to assign somebody to him, right? And so now we know the process to take. The process, it's a systematic process. You only deviate when you have to deviate, right? So when you all go into your clinicals and you're doing your clinicals, don't forget the process. It's very simple. Start with the non-involved side and go to the involved side, because you always got to have their baseline normal. The only way you get that is if you do their non-involved side. That's the only way you know their baseline normal. Their baseline normal for shoulder flexion may not be 180 degrees. Their baseline normal may be 150 degrees. And the farthest they can go with the involved arm is 0 to 80 degrees. You see? But now you know, okay, the most I may get is 150 degrees with the involved extremity with shoulder flexion. That's this patient's normal. So you shouldn't expect to get 180 degrees of shoulder flexion. Does that make sense? Don't drop the ball on that. Don't go to your clinicals and do what do they call it? A brain fart? Is that what they call it? A brain fart? Yeah, yeah. Don't do that. Unless come with you like, yeah. All right. So don't do that. All right. So, all right, that's it. That's all I want.